Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm pleased to bring to you another great interview. This is our first regular episode after having gone through 12 interviews from content presented at the 2021 AAMPT conference. We hope that you enjoyed the information these presenters brought to you, and that we'll see you later this year at our next conference, which will be in San Diego, California, from October 26th to the 30th. Let's not get too far ahead of ourselves, though. Today's guest is Dr. Seth Peterson. He is a physical therapist with residency and fellowship training, as well as a board certification in orthopedics. He is also the founder of the Motive Physical Therapy Specialists, which is a private practice clinic located in Oro Valley, Arizona. Additionally, Dr. Peterson maintains a faculty position at A.T. Still University, while also teaching in local and national postgraduate programs. Dr. Peterson was our guest for episode 41, during which we talked about telehealth. This time around, we invited him back to the show because he was recently the author of a peer-reviewed case study titled Physical Therapy Management of a Patient with Persistent Groin Pain After Total Hip Arthroplasty and Iliopsoas Tenotomy. I'm positive this is going to be a fun conversation, so let's avoid any further delay and get to the interview. Dr. Peterson, welcome back to the podcast. How are you doing?
I'm doing fantastic. Thanks for having me back, Stephen.
We are very pleased to have you back, and it's been a while, but you, as I mentioned in the introduction, were here before. By my count, it's been exactly 50 episodes, which is not counting our somewhat infrequent bonus episodes. So it's a nice round number to have you back on the show. And in particular, I'm really excited to talk about the case that was just published that you were the author of. As it was stated in the introduction, this is a case that deals with somebody who is status post total hip arthroplasty, and that can be a really controversial topic for some people, especially when it comes to a topic like manual physical therapy. So when I saw the title, I just knew I wanted to dive into the case and see what it had to do. And then after reading it, I knew that this would be a spectacular conversation to have on the podcast. So I think one of the points that can be said in general about total hip replacements is that they're often seen as being easy. You know, it's that easy patient, the easy rehab. Sometimes they don't even need much therapy, but, you know, as we'll dive into here, that clearly isn't always the case. And I was just wondering if you had any opening thoughts on that.
Yeah. And I think you see that with a lot of joint replacement surgeries or even like post-op patients. I think physical therapists kind of almost tune out for the cases. But yeah, I mean, they're definitely difficult cases. I don't even know if surgeons really appreciate you get complex people who have joint replacement surgeries. And so of course you're going to have some cases that are more complex. And then this case in particular was an example where there was a complication that happened and I guess all the events that happened after that were kind of some of the things that made the case complicated.
We're going to dive into that momentarily, but before we get to that point, can you outline for us what some of the more common complications are after a total hip arthroplasty?
Yeah, sure. So I guess depending on the source, it's about 2 to 10% of people after the surgery that experience a complication. So the most common complication after total hip replacement is what's called aseptic loosening. That occurs in about a third of patients, again, depending on the source, but that's basically just loosening of the implant over time, which can occur for a number of reasons. There's biological reasons in the patient's own body or chemical reasons as a result of the surgery or like the components themselves. And the surrounding bone in that case gets kind of angry and the patient can develop symptoms because of that. The second, and I think the one that physical therapists think of maybe more often, is dislocation, which is probably the one, like I said, we're most familiar with in physical therapy. It's surprising to me how commonly this occurs, though. I mean, you have to think about it in terms of the risk over time. Interestingly, there are sources that say dislocation occurs almost never, like 0.3% of the time. And then there are those that say it occurs 17% of the time after surgery. Infection is another one. That's usually listed as the third most common complication. And then what happened in this case was iliopsoas impingement, which is something we'll talk about in the context of this discussion, but that's about 4% of the time after surgery. So not nearly as common as some of the other complications, but still that's about 1 out of 25 people.
If we can just go back for a quick moment there, and I don't think I've ever heard this number before. You have a source that says up to 17% of people dislocate?
Yeah, there was one study. And so it's interesting. If you look at that source, they tracked it over, I believe, the kind of the lifespan of that hip replacement. So we think about it as, I think in physical therapy, and the relative risk of dislocation is greatest right after the surgery. But if you look at it throughout the lifespan of replacement, then yeah, up to 17% is what one study showed. And again, they're really low numbers, like 0.3% of the time also. So it's tough to really give a precise estimate, I think, based on my read of the literature.
As is very often the case with many healthcare topics in peer-reviewed scientific literature. But my initial response to that is, I've been doing this for 18 years, and I would be hard-pressed to count, up to one hand worth of fingers, the number of times that I've known a patient to dislocate. So I don't know, it's interesting. And like you said, the science can be complicated, but moving on, let's go to that 4% number, the hip impingement syndrome. Talk to us a little bit about how that relates to the recovery period for a patient that's had a hip replacement.
Yeah, so we're used to talking about femoroacetabular impingement, or FAI, as something that occurs due to bony structures, usually in the hip, but that stuff changes after a total hip replacement. So, as many have recognized for quite some time, you can still have a similar presentation in people after hip replacement surgery. So, why is that? There are a couple theories about this and different mechanisms that have been proposed. So, in surgery, a lot of the art, if you will, is ensuring that the hip is as close to the person's normal anatomy afterwards as possible. So, the components kind of match what the typical expected shape of their acetabulum might be. The components fit the person's body. They have good congruency, and the tendons in the area move well over the prosthetic components. But with this impingement, after total hip replacement, it seems like one theory that occurs in patients is that there's this acetabular rim component, that there's this excessive prominence, particularly anterior inferiorly, or surgical screws, or a prominent femoral collar. So basically similar issues to what you might see in typical FAI, but now we're talking about components in kind of the adjacent soft tissue.
Thank you for that description. I think it was very helpful. And can you please briefly walk us through what the current evidence states about this type of hip impingement after an arthroplasty and where the evidence is lacking? Or perhaps stated differently, knowing this evidence that's out there and some of it that's not out there, how did that inform you in terms of moving forward with this case in particular and how you manage the patient's situation?
Yeah, so what I just described is a theoretical mechanism. It's not certain that that's what's happening, but there is some pretty convincing evidence that the iliopsoas tendon in particular does undergo a bit of trauma in these cases, particularly when these kind of surgical components get in the way. So, for example, there are studies describing these large hematomas and tears in the tendon. So, this cup sizing, orientation of the cup, retroversion of the cup, and probably some, patient anatomical factors play into this. So there was this paper by Shaffer and colleagues that compared two different surgical techniques to each other. One was a revision, which kind of makes sense after this, if you get a presentation like this after hip replacement. And the other was a tenotomy. The functional outcome between those two groups in that study was pretty similar, but the complications were actually much higher in the revision group, like 5 times higher. So they recommended tenotomy, and the success rate was pretty good for that, like 70% or so. But obviously, when you sacrifice that tendon, which is one of the primary movers in hip flexion, you sacrifice some hip flexor strength.
That's some very interesting background evidence. And it's just so fascinating to think about the possibility of losing the hip flexor like that. It seems like it would be perhaps intensely life altering from a movement perspective. But to be honest, I don't think I've ever seen a patient who underwent one of those surgeries.
Yeah, I've only seen a couple, and it's actually interesting. This case, it wasn't. I think it was published in 2020, so not that long ago. And I think I've had more patients reach out to me in my clinic because of this case than any other case report I've published, and there've been quite a few. So it kind of leads me to believe these patients are out there, and to some degree, they're kind of left out to dry. There's not really much that they can do for them surgically.
Yeah, that's super fascinating. And I'm glad you just transitioned more towards this case because that's what I want to hear next from you. Who was the patient? What was the case like? And I guess in general, what was their situation from a healthcare perspective?
Yeah, so this was a 72-year-old retired internal medicine doc. He had actually a posterior approach total hip replacement 4 years before I had seen him. And immediately after surgery, reported having this pinching feeling during active hip flexion. So, again, at this point, I didn't see him after the original hip replacement. So, he had this pinching and he kind of lived with it. Eventually, he went back to the same surgeon and ended up having a tenotomy by that doc. And coming out of that surgery, still no resolution in that pinching feeling. And what happened was what often happens is at that point, the surgeon said, okay, well, your physical therapy's problem now, and kind of dumped him onto our clinic. So he was a really healthy guy who would go out on kind of these recreational bike rides. He had a pretty average BMI. He wasn't really an exerciser. He went on these short daily walks as well, that sort of thing. But he just had this pain lifting his leg to get into the car and to tie his shoes. So it was this pinching feeling with active hip flexion, particularly when he was seated.
I'm kind of sad to say that it's not surprising that this individual went on for 4 years with a symptom that, let's say, theoretically, because it didn't happen this way, so we don't know for sure, but theoretically could have been fixed by seeing a good manual physical therapist such as yourself. But regardless of that point, what were the examination findings? And from a clinical reasoning standpoint, in what way did you use those findings to assist from a differential diagnosis perspective?
Okay, so a couple things stood out to me with his presentation. So, one, he kind of stood with excessive hip extension, and he didn't have a lot of strength at all in that leg, just generally. He could only stand on it for about 6 seconds, and he just generally looked unsteady. He walked with a typical Trendelenburg gait. Active hip flexion, as I stated before, was painful. He could get to about 100 degrees actively, and then he had this pinching feeling in the groin. When I passively moved his hip, there was a firm infeel at about 110 degrees, so a little bit further. And external rotation of his hip was limited as well. So when we talk about, version of the cut being a factor, I think maybe that was, potentially a factor in this guy's case, since that can limit flexion and rotation. Then examining his hip, if you log rolled it into internal rotation, so he's lying supine and with his leg out and rolling it inward, that was painful. So here's a guy that physically cannot get into external rotation much, and internal rotation is painful. Then examining the passive accessory mobility of the hip, that was limited as well, inferiorly and laterally. So as a manual therapist, you're now looking at, okay, there's some limitations in movement, some limitations in passive accessory mobility. So starting to think maybe, these are some impairments that you could treat. Like one initial thought that I did have as somebody who sees a lot of lumbar cases was that this might have been a missed lumbar condition or a thoracolumbar condition referring into the hip. But examining both of those areas were pretty unremarkable. So again, it was kind of a nice case to write up and challenging for this patient, obviously. But in reality, it's just sometimes not always that clear. you'll often get people, and like I said, I've seen a couple patients since then with similar presentations, not quite to the extent of this guy with the tenotomy as well, but you get people that have lumbar or low back pain and hip pain. And then that makes it a little bit more challenging from a differential diagnosis perspective. And also, I think the question comes up, and I mentioned this in the discussion of the paper, if it's the iliopsoas that's painful and that's been released, what was still being aggravated? So one potential theory about why this gentleman still had symptoms is that maybe there were some other tissue in the anterior hip that was involved, such as maybe a redundant piece of the joint capsule. But really, I didn't know to be sure at the time, kind of defaulted to an impairment-based treatment approach. And still, I don't think, and discuss this in the discussion of the paper, I don't know that we can still say exactly what we point to a specific pathoanatomical structure, which is a bit interesting.
It certainly is interesting. And as a manual therapist listening to you, of course, I hear this discussion of movement and tissue restrictions. I love your point about how it's hard to be, exactly precise when it comes to which tissue. But based on what I heard, it tells me we have to get things moving. I see this all the time in patients that have hip pain, either with or without a joint replacement. And I find that in the clinics I've worked in, a lot of times I'm the only one that's comfortable pushing on, stretching out, mobilizing that total hip replacement joint because everyone else is just scared of that whole potential for dislocation. And my response is usually, well, they describe tightness. They look like they have tightness when they move. I feel it when I move the limb. So walks like a duck, etc. We're gonna have to mobilize it.
Yeah, maybe if we could make that point here, it's safe to do a joint mobilization after total hip replacement surgery. I think where most PTs are concerned is about dislocation. And I personally am not aware of any cases that have been reported where a provider dislocated the hip during a joint mobilization. So if we talk about some theory, it'll start to make sense. Right, the relative risk of dislocation, as I talked about, is greatest right after the surgery. So if it's, especially with this patient, 4 years later, the risk is going to be lower just to begin with. But you theoretically could dislocate a replaced hip at any point after surgery. So you might want to be careful bringing the hip into really extremes of, adduction, flexion, internal rotation in a typical patient all at the same time. Maybe not doing a posterior glide, things like that I don't think most PTs would even attempt to do anyway, hopefully. But that said, there was a study in 1990 by Arvidsson that found just to create separation of the joint surfaces in normal hips, I believe was 90 pounds. And then in a randomized control trial, Estebanez de Miguel, they kind of compared higher forces in people with osteoarthritis of the hip during joint mobilization. And so they had a group that they were doing joint mobilization with higher force. And in the highest force group, they were applying 15 pounds of force. Based on that, when we do a joint mobilization, we might not be creating much joint separation or separation of the joint surfaces. So to think that you're going to dislocate the hip, I think you're pretty safe that that's not going to occur.
I would not have been able to cite those specific references, but they're very consistent with my understanding of what's going on when I'm working with one of these hip joints. And from a cautionary point, I should probably say, yes, of course, I push on these types of hips more gently than someone who has not undergone the surgery. I like to go with that lower force intensity for a longer duration. And I certainly won't combine them into multiple movements at the same time and then do something super aggressive. I like to be what I'm going to label reasonably cautious about it. But if it's a tight hip that needs to be mobilized, then the patient needs me to mobilize it and I'm going to dive in. Which, if I can add to that, brings us to what at this point might be at least partially obvious. Based on the findings in this particular evaluation, what specific treatment choices did you make? And perhaps most importantly, how did the patient respond to those treatment interventions?
Yeah, so like I said, This is kind of where it gets a bit interesting in this gray area that we often find ourselves in clinical practice. But I just looked at it as, what can I change in this individual? What's the most important thing to move him towards his goals? I'm not going to grow his hip flexor back. I would charge a lot more money if I could do that. And I can't decrease the size of the cup. So I took a step back and just asked, what would I do for a typical FAI patient? If I don't even think about the pathoanatomy for a second, what seems to work with those patients? And then I tried that on this guy and was surprised that it did seem to be effective in this case. I decided to go after hip mobility through joint mobilization and try to get him back to having more confidence in weight bearing. We initiated some hip strengthening, particularly with his glutes. And we did try to work on hip flexor strength, but as we'll talk about, I only saw him for 3 weeks, so that didn't change too much, which I think was pretty expected. We kind of attempted it, but yeah, there wasn't much improvement as far as the strength, but we'll talk about some of the outcomes we did see.
Yeah, let's dive right into that. What were the outcomes? And, maybe you can talk about immediate outcomes and longer term outcomes, but I'm sure the listeners, and myself included, although I have already read the paper, want to know, how did it change this gentleman's life? Did he become more normal? Did the problem go away? Was the physiotherapy successful?
Yeah, so we saw each other for 6 visits over the course of 3 weeks. And his pain, and again, think about this as someone having pain for 4 years. I don't know that that's, super typical, but his pain did and function all improved beyond the minimal clinically important improvement. He met all of his goals. So he could tie his shoe, he could lift his leg up to get in the car. He did have some difficulty in terms of weakness with active hip flexion and sitting. That didn't improve much, as I alluded to. It was over the course of 3 weeks. You can imagine we're up against the physical tenotomy of one of the primary hip flexors. But I do think, there are other hip flexors. So I think that's something that maybe is possible to improve. It just is probably going to take longer than 3 weeks.
I would certainly agree with that. And it sounds like a great outcome. Of course, anytime you meet the patient's goals, that's a victory for everyone involved. And I love the general point about how, despite the fact that this patient can easily be classified as a quote unquote chronic pain patient, I think it's very important to remember the difference between chronic from a timeline perspective and chronic from a pain mechanisms perspective. Yes, there's sometimes overlap, but there's not always overlap. I've seen patients with 15 years of pain, and they're still very mechanical. They're still very much in that acute phase. You move the joint around, you get the muscle working better, and then bam, they're suddenly all the way at their goals, and you didn't have to work that hard to get there. And I really loved in this case how, despite the complicated nature of it, despite the post-surgical ×2 nature of it, despite the timeline nature of it, you were able to cut through all of that and very succinctly get the patient to where they wanted to be, which was, again, meeting their goals.
Yeah, I think you made a good point about not necessarily thinking that just because pain has been present for a long period of time, that we need to put someone into a box of having primary nosoplastic pain, for example. So there was a good paper in JOSPT, I think Taylor and Carey presented this case of a patient that went from provider to provider in physical therapy with different diagnoses. And ultimately, they had peripheral arterial disease. And after surgery, their leg pain was resolved. But, I think sometimes it's easy to lump patients into these buckets or not keep an open mind when we should. So I think that's one of those things in patient care that we should all strive to do, is try and help the patient however we can, not give up on them, and never fully close our mind in terms of what the potential is for improvement.
Well, I could not agree more. And I think that's an absolutely beautiful point to end on. So, Dr. Peterson, it has been a distinct pleasure having you back on the podcast. I look forward to seeing the work that you generate in the future. And until that time, I hope you enjoy clinical practice and stay well and healthy.
Thank you. You too, Stephen.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.